Good morning, everyone. Welcome to NRBP's fourth Return to Work series webinar. I'm Barbara Kaufman, Executive Vice President and COO at Newark Regional Business Partnership. And on behalf of all of us, I'm very happy to welcome you this morning for what I think is going to be a fascinating program. First, I want to thank Quest Diagnostics for sponsoring the Return to Work series. And I'm going just to tell you a little bit about some of the other programs that we have coming up, continuing this series, and also some of the other things that are happening, and then we'll get right into the program. Tomorrow, we will have our happy hour from 5 to 6 p.m., and we'll be hearing from DJ Lucatelli at Sweetwater Coffee and Tea, and he'll be talking about a coffee drink that you can make at home. And he'll be doing a short demonstration, and then we're going to be having open conversation as close to an in-person networking as we can get. Wanted to mention two programs that are not NRBP programs. Today at 1:30, Mayor Baraka will have a town hall, and tomorrow morning, NJPAC's Business Roundtable will include Tammy Murphy, the First Lady of New Jersey. Then on Monday, we're continuing our Return to Work series, Roadmap to Return, and we'll be hearing about things that landlords and tenants and also employees should know, a step-by-step guide for getting back into the workplace, things you can do to prepare your workplace so that you ensure that your employees are safe and also feel comfortable coming back as they need to come back. Tuesday, we're going to be talking about how to present a great webinar. Thursday, we have our continuing happy hour. We have our continuing happy hour with NJPAC on the 19th. We have Newark. I'm sorry. The great webinar is on the 20th. I apologize. NRBP Nexus is on the 19th at 2. These are small group networking. If you want to do that, you'll need to let us know as soon as possible because that fills quickly. And that's going to be more one-on-one conversation. Then our happy hour on Thursday will be with NJPAC to learn about some of the different programs that they're offering that you'll be able to participate in right from whatever room you're logging on through. And then on the 27th, we're going to be talking, really drilling down on psychology and the sorts of things that people are concerned about. And the 28th, the happy hour, is with All Points West Distillery. So that's a quick summary. Thank you again to Quest and to all of our speakers. All of the events that I mentioned are on our website, newarkrbp.org, or you can contact any of us. We really want to be able to be available to you to help you make connections, so please do reach out to all of us. Our presenters are going to go in the order that we agreed upon, and they're going to go without interruption. I'll come back at the end to field questions, and then Chip Halleck, our President and CEO, will close the program. So I am going to mute myself and turn off the camera and welcome Perry Halkitis to present to give our first presentation. Thank you.
Well, thank you, Barbara. And as Barbara said, my name is Perry Halkitis. I'm very happy to be here with you and to hope that this finds you all in good health. What I thought I'd do today is talk a little bit about public health aspects of COVID-19, in particular tracing, which is something that's gotten a lot of attention. But as a way of framing all of this, I think it's incredibly important for us to remember that when we're talking about COVID-19 or we're talking about most illnesses in our world today, that these are not just biological phenomena. And this idea of a biopsychosocial perspective, one that marries biological phenomena with psychological phenomenon and social and structural phenomenon, is the basis of a model that George Engel first developed in the late 1970s. And it recognized that human beings are more than just vessels or that contain pathogens, but that they're real human beings that have real lives that are navigated by emotions and by social systems and structures that affect their health. And I think that's a really this might seem like an academic point that I'm making, but it's not an academic point. It is an incredibly important point for us to think about, because I think too often healthcare delivery forgets that aspect. And so when we think about COVID-19 in particular, the biological issues that we're thinking about, some of them are the virus itself, the symptoms, the comorbidities, the psychological and behavioral issues that sort of surround this disease, deal with the risk behaviors that place people at risk, but also which place people that they're around at risk, the emotional reactions people have to this illness, and the mental health drivers that make people potentially more at risk than others. Finally, and importantly, and something that I've been thinking about in my own work a lot in the last few years, is the role that access and social support and health disparities play. How do people with different lives who have different access and different support systems, how does that make them more vulnerable to diseases? So this biopsychosocial manifestation asks us to think about this disease in this more broad way. To battle COVID-19, I've sort of coined this term 4T: target, test, treat, and trace. And so I'm going to sort of walk you through these ideas, but the notion here is identifying people, testing them, and I'll talk about talk a little bit about both testing, both PCR testing and antibody testing, just mention them here. Treat people with whatever symptom relief we have, or whatever pharmacotherapies become available, and then tracing, which is really the focus of my talk today, which is how do we continue to spread the disease from going any further. And so we have to think about all of these elements, virologic testing, all of these things that are listed on the chart on the screen here, as things that we have in a toolbox. So we have virologic testing, that's a check. We have treatment, we're able to treat symptoms, that's a check. We don't really have that many effective pharmacotherapies, so they're being developed. Antibody testing or serologic testing is out there, but it is fraught with numerous problems. Contact tracing is a technique that's existed in public health for 100 years. Physical distancing we know works. Isolation and quarantine may work if people follow it, and vaccines ultimately are under development. So the World Health Organization issued this guidance on May 10th of this year that says that essentially an effective comprehensive strategy for controlling COVID-19 is case identification, isolating, testing and care, and contact tracing and quarantine. And that if we were to use those, if we would embed contact tracing within this larger arsenal, we would have a more effective way of controlling the disease. So in order for contact tracing to actually work, we have to have a large enough battery of tests. And as you may have heard in the news over the last few days, tests are being rolled out more. In the past, only people who were symptomatic could get viral testing. That seems to be beginning to evolve and change. We need to have one centralized system. And you may have heard yesterday the governor announced that we're going to be using ComCare here in New Jersey as a centralized system, as a way of collecting data for people. And I just wanted to say this up front here. It is very easy for people to feel that contact tracing has some underlying evil, conspiracy-related aspects to it. But in fact, data that are collected are kept confidentially, and then they are gotten rid of. Every effort is undertaken to ensure the confidentiality of people, and to ensure that people remain safe, and to ensure that people don't feel that their lives are at risk because they're providing information. In addition to that, the other elements of a successful program include support for isolation and quarantine, which is in making sure that people have a place to actually be and live when they are infected, which is a complicated matter, especially for people who are housed in ineffective ways or who are homeless. And so this is something that has to be at a front and center as we think about isolation and quarantine. And then, as important as any of these, effective, clear, and collaborative communication with populations. In order for our testing program to actually work, a tracing program, we have to be clear with all the populations that we're working with what this is actually doing. So we also have to have a number of well-trained contact tracers, and you may have heard the governor yesterday speak about working with the Rutgers School of Public Health. We're very proud of that. And what I really love about that is that we're going to get an opportunity for our students who are really engaged in this kind of learning to actually work. And these students are dedicated to social justice and are dedicated to the well-being of the people of New Jersey. So it provides an opportunity for them to work with the populations that they are a part of. It also means that we have to respect and coordinate all our efforts with local health departments. While one system is definitely being suggested, there's going to be tailoring, and there's going to be nuances within local health departments about how they operationalize the tracing program. We have to include public health experts. We have to make sure that we have full knowledge of local populations and communities. Not all populations are the same. Not all communities are the same. We need to have seamless integration with accessible healthcare so that if people do test positive, that we can link them to care in effective ways. As I said earlier, we have to have maintenance and coordination of data management, and most importantly, assurance of privacy and security, which is front and center of any testing program. So contact tracing is kind of like detective work, as it said in this New York Times, in this Time magazine article. And what basically happens is that trained interview staff who've talk to people who've been diagnosed with the disease to figure out who they've been in contact with. So if I had been diagnosed with a disease, they would talk to me. They'd find out what my social circle was, my social context was, who I was in touch with, and then they contact those people to determine whether or not they could be exposed to the disease also. By doing that, you're able to contain the pathogen. And so this has been used very effectively in the Ebola crisis of 2014, but it's also been used in HIV, and I've been doing HIV work for over 2 decades. And what you see in the picture on the right is, an example of contact tracing where, essentially by identifying one person who's infected, you can map out a whole network of people who that individual may have infected. And that's really critically important. And then informing those people and preventing those people from further spreading the disease. So contact tracing consists of like 3 main elements. The first, I would say, is informing, supporting patients with confirmed infection, helping the patients recall everyone who they've had close contact with, and then public health staff then warn exposed individuals about their potential exposure. So to protect patient privacy, contacts are only informed that they have been exposed to a patient with infection. They are not told the identity of the patient who may have exposed them. And that's really critically important in terms of the safety of people. So how we roll this out and how we share information with people is a very big part of a contact tracing program. Number 2, in addition to informing, there is then what I call supporting. That contact tracers are provided with contacts are provided with education, information, and they are to make them understand their risk. Just because you've been near someone who has COVID does not mean you necessarily were infected. So they are told what they should do to separate themselves from others who are not exposed, how to monitor themselves from illness, and the possibility that they could, getting to understand that they could spread the infection if they don't quarantine themselves. Again, if person A is with person B and person A is infected, person B may or may not become infected depending on the kind of interaction that these people had. And then number 3, I would say the element of it is of tracing. The third important element is strategizing. So contacts are encouraged to stay at home. Contacts monitor themselves. Public health staff continue to check in with them. And then if contacts develop symptoms, they are then connected to care in a real-time manner. So who is a contact? A contact for COVID-19 is defined as anyone with the following exposures to a person who's been infected from 2 days before the onset of the illness. Anyone who's been within 3 feet of a COVID case for more than 15 minutes and/or has had direct physical contact with a COVID-19 case and/or provided direct care for patients with COVID-19. All of these are indicators of what might make somebody potentially at risk for getting infected. It is not a 100% guarantee. Right? There is probability here. It depends how much somebody sneezes or spits or how much the air particles carry the infection across to the other person. So it is not a surefire deal that somebody who is next to another person who's infected will actually become infected. But these are conditions that might make the likelihood of infection greater. We also should know, as you have heard in the news, that there are people who are asymptomatic. So if confirmed cases are asymptomatic, contact should be managed in the same way as they are with a symptomatic case. So if we identify a person, and the problem has been we've not had people testing who are asymptomatic with viral load testing, because it's been designated primarily to people with symptoms. But now as it gets rolled out, we may identify through viral load testing people who actually have the virus but are asymptomatic. And those individuals also, we have to follow the same procedures with them. So informing and working with contacts is an incredibly important part of the process. The process and the rationale for why we're doing contact tracing and quarantining needs to be explained. We have to explain how they will be quarantined, what the symptoms look like. So as we have to make it super clear to people so that they feel safe, that they are being traced, that they are potentially that we are making the contacts feel safe, and we do that by providing information in a manner that is accessible and easy to understand, that has health literacy at its front and center, but also recognizes that there are different cultures and different parts of our population that interact with the medical profession in different ways. We know there's huge amounts of medical mistrust out there, and for us as in public health, we work diligently to make sure that the messaging is clear and effective so we can chip away at that medical mistrust. This is just a chart from the World Health Organization about the kinds of information that's gained, that is achieved or is gathered during contact tracing, demographic information, type of contact, disease assessment. And finally, I guess what I would say is that one of the most important for me as a person who's a public health psychologist, as my friend Frank Ganassi here is also a psychologist along with me, and what we think about a lot is how we deal with people on this emotional level and on this human level. And so for me, as a public health person who's also trained in psychology, openness and transparency of the process has to be key. If we want people to actually, in our state, buy into this idea that tracing is effective, we have to make it clear to them what tracing is. And at our school, we're going to work really, really diligently to make sure that happens. Building trust with the populations. If populations do not trust what we're doing, then they're going to reject the process. And again, this is about ensuring people that their information is safe. Effective training of tracers means having them have the knowledge, the skills, and importantly, the ethical training that is required. People are not just effective tracers just because they know how to gather their data, but tracers are effective if they are actually following a set of rules and values and ethics to make sure that the information that they're gathering stays within them, that they're protecting the confidentiality of people. And ensuring the confidentiality of people has to be one of the most paramount principles that guides all of this. And finally, recognizing that in a state like ours or in a country like ours, there's a diversity of life experiences. People hold multiple intersectional identities. People have many roles in their lives, different cultures, different races, different genders, different sexual orientations. And so as a result of that, we have to make sure that we attend to all the diversity that exists within our state and recognize that not every single person is the same type of person. So as you know, as I said earlier, Governor Murphy announced this yesterday. It's part of the plan for restoring economic health, and he very eloquently talks about the road to economic health is in fact informed by public health. I'll just leave it at this. Here's some information for me if you want to further follow the work that we're doing, and thank you very much for being such an attentive audience this morning, and I look forward to speaking with you.
Thank you, Perry. We're going to be moving on to our next presentation momentarily. Larry Hsiao will be starting.
Hi, good morning. Thank you, Barbara. My name is Lawrence Hsiao. I'm the medical director of the East Region at Quest Diagnostics. I'm based in Teterboro, the facility in Teterboro. I will be focusing primarily on the testing aspect that is currently available for SARS-CoV-2, and in order to really talk about testing, I'll touch upon some of the biology of the virus, since we really can't talk about testing without understanding some of the biology behind the virus. The first thing I wanted to really shed some light on and discuss is really about the timeline of the testing development, not only from a technology and as well as a capacity standpoint. There really has been quite rapid progress in terms of the availability of testing. If you take a look at the timeline on the slide, basically since the end of February, and we're talking about the very end of February 29th, when the FDA announced the availability of testing for independent laboratories to develop laboratory-developed tests, and to begin testing using those methods prior to obtaining an emergency use authorization. We've gone from just a handful of PCR tests to currently, as of yesterday, over 60 different methods from different manufacturers and laboratories of PCR and serology tests. And along with this increase in authorized testing platforms and methods, there has been an overall increase to testing capacity in the US as well. So as I mentioned, currently there, on a very high level, there are two basic types of methods or tests available. These include molecular or PCR-based tests and serology. Actually, recently, just this week, a third type has received a emergency use authorization from the FDA, and this is a antigen detection assay. This is the first one that has received a EUA, and so I won't be going into too much detail about this type of assay at this point, since it's still very early and it's not really clear whether it's at a capacity that will significantly be able to impact our testing strategies. So, in essence, I'll just cover mainly the two main types of tests that we have available, which is PCR and serology. So, starting with PCR testing, as many of you probably know, PCR tests target specific sequences in the viral genome, and through amplification, it assesses the presence or absence of the viral genome. This actually translates into presence or absence of virus. As a result, the PCR test are usually highly sensitive, with limits of detection down to a couple hundred copies per milliliter, and they're also highly specific since they actually target regions that are conserved within the viral genome and that are specific to COVID-19. However, if you take a look at this slide, this is a slide that represents the not only the viral replication as well as the immune response, and focusing on the green line, which is indicating the RNA or detection of RNA as virus replicates. What this shows is that the virus starts to replicate after infection and increases in concentration over up to about 7 to 10 days after symptoms, with day 0 being the day that symptoms develop. However, it begins to decline after the 7 to 10-day period, and this could vary depending on how effectively the patient actually clears the virus. And the net result is that after 7-10 days from symptoms, the PCR test begins to decline in its ability to pick up the disease, which is one of its major limitations. In addition, the PCR test, because it's really looking for the presence or absence of virus, it actually gives us its limitation is that it only gives us a view of the disease at a specific point in time, which is when the sample is collected, and it does not give us any historical information about exposure. A patient could have been exposed 2 or 3 weeks, actually had the disease and infected. But if we test them later or past the window, we would have no insight into that. The major advantage, of course, of PCR testing is that it gives us a current view of whether the virus is present or absent. And currently, this is actually the best test we have to assess if a patient has the ability or possibility of transmitting disease. I think it's important to also point out is that I said that this is the best that we currently have, and that's because that evaluation or the idea of the ability to transmit disease is actually based on a very large assumption, which is that the presence of viral genome equates to ability to transmit disease. Under the current environment, it's a safe assumption because, but as we know from other viral testing using PCR and molecular techniques, it is not always equivalent. So. Now with that, I'll move on to serology testing. PCR tests, unlike serology, gives us the current view, but it's actually looking for viral genome or the presence of virus. Serology testing, on the other hand, is really a evaluation of the response of the host immune system to the virus. In terms of the current serology tests available under the FDA EUA, there are 3 basic categories. There's tests that detect or target IgG. There are those that target IgM and IgG. And then finally, there is the total antibody test that is basically a combined view of IgG and IgM. And so there are advantages and disadvantages all these types of tests. The main difference in terms of methodology, whether it targets IgG or combined IgG and IgM, is that the 2 basic methods are some type of ELISA equivalent method, which is really a lab-based method, versus a lateral flow, which is more of the point of care type methods. The main difference between these methods is that the ELISA or lab-based methods tend to have a higher capacity, are more automated, and therefore have higher throughput. The serology tests based on lateral flow are generally more of a point of care setting. They tend to also, from a performance standpoint, have a lower sensitivity because their limits of detection tend to be higher than that of the lab-based techniques. In terms of the lab-based tests, I mentioned that they can either detect IgG or total antibodies, which is a combination of IgG and IgM. The main advantage of including IgM, if you refer to the chart again, which is the yellow line, IgM, you'll see that the IgM becomes detectable early on in infection, which is it starts at about a day or 2 after symptoms. This gives the IgM the advantage of being able to detect earlier cases of infection. However, one of the things to also consider is if you look at the green line again, which is RNA, which is what the PCR test detects and which is the primary test we're using now for early diagnosis of infection, it actually overlaps with IgM to a significant degree. And therefore, combining the PCR test with the IgG test, in essence, covers that window. In addition, IgM tests being an early response antibody tends to be less specific than IgGs, and we see this in other viral infections as well. So with the use of a total antibody test that includes both IgM and IgG, there is the risk that the IgM component can compromise specificity performance. So IgG is really what we're trying to detect with our current serology tests, and there are a number of good reasons for why IgG is what we're looking for. The primary reason, of course, is IgG in terms of viral infections is generally the antibody class responsible for protection and immunity. We know from the previous SARS from 2003, most patients develop a IgG response after its infection by that virus, and that the neutralizing antibody or protective antibody is an IgG. In addition, we know from early human studies as well as animal studies of the current SARS-CoV-2 virus that most patients develop a IgG response after recovery from the disease, and that most of the patients with the IgG response do have detectable neutralizing antibodies. In addition, we have evidence that infusing convalescent plasma from recovered patients with SARS-CoV-2 into new patients who are currently infected with SARS-CoV-2 actually shows benefits, which strongly suggest that there are humoral factors that help fight the disease. So based on this, what does the current IgG serology tell us, and how do we utilize it? The current IgG serology test is actually most beneficial within a population or as a surveillance tool. Within a population, it will tell us not only the prevalence or exposure rate of COVID-19, but within that population that has been exposed and have detectable IgG, we know on a population level that the majority of those individuals are protected or will develop some type of neutralizing antibody. However, what we do not know from the current test is that on an individual level, we cannot tell whether a specific individual is among the majority that have developed the protection or the minority that did not. Therefore, the current serology tests that we have today are not able to determine immunity or protection on an individual level. It is more geared towards a population type of data collecting and view. So finally, this is the last slide that I have, and really it's meant to show where we think the SARS-CoV-2 immunity, antibody immunity or protection will end up. Like I mentioned before, the SARS-CoV-2, their early evidence does show that that most patients who are infected and recover do develop IgG responses, and that most of those who develop the response do form neutralizing antibodies and therefore are protected. And so based on that data and the data that we have from previous similar viruses, including SARS-CoV-2 from 2003 and the MERS coronavirus, we believe that the SARS-CoV-2 virus will end up in the short-term immunity post-natural infection category, and based on the length of time of protection of the previous viruses like SARS-CoV-1 and MERS, the protection should or antibody levels should last in the 2 to 3 year range. And so that's where our current data and understanding stands. And with that, we can we'll move on to the next presentation. And thank you for your attention.
Thanks, Larry. Frank will be joining us in a moment to continue and talk about the mental health aspects.
Hi, Frank Ganassi. Are you able to hear me?
You're good.
Good. My name is Frank Ganassi. I'm President and CEO of Rutgers University Behavioral Health and Senior Vice President for the Behavioral Health and Addiction Service line across RWJ-Barnabas Health System. And just wanted to present a few ideas around behavioral health and mental health issues during a time of this kind of pandemic. There was work done about 10 years ago by Zunin and Myers looking at responses to disasters. And this qualifies as a disaster, but it's also differentiated in the length of effect. Many disasters are punctuated by weather-related events and or events of shorter duration, but there are also disasters that can be months, if not years in length, especially when you think about armed conflicts or wars. But when you look at the patterns of behavioral and mental health disruption, there are many, many similarities. And so let me just give you a little framework. It turns out that in anticipation of a disaster or a pandemic, there is this pre-disaster period that is often identified by a sense of warning. Many individuals are anxiety-ridden about that warning. Others tend to engage in denial about it or minimizing the threat. I think we saw both reactions in the US and across the globe. This is also a trigger for many. For those individuals who have previous history of post-traumatic stress disorder or may be predisposed toward anxiety disorders, that pre-anticipatory period can create a lot of disruption even before the actual event occurs. And then there's the impact. And I think for us in this crisis, the impact began to happen as we saw the initial effects coming out of China and then more secondary events happening in Italy. And people could sense that there was a growing momentum and that this disorder was highly infectious. I think many people then moved from denial to a real sense of concern that this looked more imminent for them. The impact occurred, and very often after that, psychologically, for individuals, there's this period that can last anywhere from several weeks to several months. We're still in a little bit of this period now. It's often called the heroic or honeymoon period. And during that period, a lot of activity is driven by adrenaline. People feel highly energized. Healthcare workers, first responders are often considered to be the heroes of the day. And they're often driven by a combination of, I think, adrenaline and caffeine. You'll see a lot of outpouring of gratitude for that. And during that hero phase, you're going to see a lot of higher activity and also a sense of altruism. That's starting to happen now. People are volunteering for food banks. That period typically lasts into the second or third, sometimes the fourth month of an event like this. And we're now beginning to get past that period, beginning to realize that this is a major disruption in normal activities of daily living. Most of us are not aware of how much we depend on those activities of daily living. Sleep-wake cycles, our school or work cycles, typical social interactional functions, and all of those are disrupted, creating a sense of disorientation for many individuals. And there really are multiple categories of individuals. For those folks who've had relatively effective baseline functioning, may not have genetic predispositions toward mood or anxiety disorders or any chronic ongoing mental health disorders, there are long adapted skill around management of stress. You'll often see a better outcome. For those who've had a previous history of either depressive or anxious symptoms, or let's say more severe and persistent mental illness, you can see a worsening of symptoms. We're beginning to see now some of that breakout. The two most common factors associated, by the way, with rises in suicide, pandemic or not, are a combination of great financial stress and a sense of social isolation. We're watching very closely now suicidal attempts and successful suicide numbers, because right now we're being faced with one of the most substantial financial crises in the country, probably since the 1930s. As many as 20% of individuals in the U.S. have applied for unemployment insurance. Many small businesses are in jeopardy, and even large companies are seeing dramatic changes in their financial picture. The stock market is down. This is creating a lot of distress on a day-to-day basis. It's also creating worry for people in their future. Those who are near retirement are worried about what that's going to mean. Younger people are worried about getting jobs. This also contributes to challenges to ongoing mental health. So we're going to watch that. We're also very concerned about this sense of social and time dilation. You're going to hear many individuals talk about the fact that it's become more and more difficult to differentiate a Tuesday from a Saturday, or that they feel like their days have kind of run into one another. Most people are not used to schooling at home. Many people are not used to working at home. And so the lines between work and home life and the lines between school and leisure activities have begun to blur, and individuals are feeling disoriented. All of this can affect mood. We're also very, very sensitive to the fact that if individuals have histories of substance abuse, or if they're currently in the midst of a substance abuse disorder, you can see relapses of substance abuse for those who maybe have been sober for a while, and a worsening of substance abuse during a time of great stress like this. We're going to watch very closely. Post-heroism phase, Zunin and Myers talk about a period of what's called disillusionment, and that is the hope for a vaccine in this case may be not months away, but it may be 18 months away, and that can create disillusionment. The hopes that stimulus money from the government, people were very excited about a $1,200 check that may arrive, but then it's not followed up by additional resources, and yet their bills continue to mount. And also people began to grapple with the realization that 2 months in, as disruptive as this has been, there may be another 12 to 14 months of some level of uncertainty and of disruption yet ahead. And that's a real sense of reckoning for many individuals. So again, we're watching very closely for that. There will be an enormous period of grief for many individuals. There will be tens of thousands, unfortunately, of deaths. There are already close to 10,000 deaths in New Jersey alone, and we're seeing, I think we're closing in on several 100,000 deaths already in the U.S. This is not over yet. The time between now and a vaccine is going to be enough time that those deaths will continue to mount, may likely get into the millions. So we are going to have individuals dealing with social disruption, financial disruption, but also dealing with grief. So we're going to be very closely attentive to that. And then finally, I just want to lead in a little bit about the fact that we need to be attentive to continuing to pay attention to the sustainability and the resiliency of our workforce. Not only our workforce in healthcare and first responders, who many of us think about now. So those of us at Rutgers and RWJ-Barnabas have been spending a lot of time, while we're worried about the mental health and well-being of our patients and families, we're also looking at ways of psychologically supporting our nurses, our physicians, our social workers, our psychologists, our pharmacists, all of our allied health professionals, who too are going through this heroism and disillusionment phase. Sometimes help givers themselves have difficulty asking for help. So we have to have multiple channels for them to be able to reach out to us. They may be call-in numbers where they can call in but remain anonymous. They may be peer support groups where they can speak to others who understand them, nurses speaking to nurses or physicians speaking to physicians. And this idea of allowing for people to access help in ways that are acceptable to them, whether it's natural support systems or ones that we can provide. History has told us that after disasters or pandemics, that the period of disillusionment eventually leads to a phase called reconstruction. And that's both psychological and also literal. And during that phase, people begin to grapple with really a new beginning. And you're beginning to hear that language now. The idea that maybe we're going to return to a pre-COVID world is something that people are slowly beginning to reconsider. And it may very well be that for the foreseeable future, even after a vaccine, because of the nature of this particular disorder, as you saw in the previous presentation, and what may be a more limited lifetime immunity, it may very well be that reconstruction, in this case, is going to be not a return to an older or previous style of life, but are acclimating from a mental health perspective and a practical perspective to a new way of life in which communicable disorders like this are part of our decision making about how we engage in both work and leisure activities. And I think this too will be a set of behavioral health and addiction challenges that we'll continue to monitor and try to provide support for. We're also going to continue to work to integrate physical health care and behavioral health care. This is something we've been working on for a number of years now, and I believe that as we recover from this crisis, integrating physical health care and behavioral health care where individuals can receive both of those kind of care in a less stigma-laden environment together will help with the sustainability. I'm going to stop with that and thank you for your time and attention. Stay healthy.
Thank you. Thank you, Frank. We are running a little bit late. Terry Burke has informed us that he needs to leave fairly soon, but I'm going to just ask him to get right into his presentation. And then if everyone can still stay on the line a little after 11, we'll field questions with the remaining three speakers. And please feel free, if your question is not answered, send it to me by email, and I'll be sure to direct it to see if we can get an answer for you. Terry.
Thanks, Barbara, and good morning, everyone. Thanks for the time today. So I was going to give a quick, brief overview around return to work, return to life, return to care, as we're seeing it from a Quest perspective. As you can imagine, we're getting lots of inquiries from employers, both large and small, and we're hearing a lot of information from those employers around what they're looking to do. So certainly we wanted to share some of that today. I've got a few brief slides, and then we'll open it up for Q&A. So just to give you an idea, as we're talking about these employers and their return to work, return to care programs, it's an interesting mix. Employers in the past really didn't have to do a lot of testing. If they did testing, it was mostly in the pre-employment screening area, maybe a health and wellness area, but really not general testing overall. And now they're being thrown into this world. So certainly this is an eye-opening experience for them. They're having to change and also create task force on their side to start to think about how they return to work and to some degree back to somewhat of a normal status if that's possible. So as employers are looking at this kind of slide kind of just shows you some of the pieces that employers are dealing with. You've got medical guidelines obviously coming out of the CDC and other areas. You've got federal and state regulations. We're seeing those pop up all across the United States. We're seeing office and site standards that are also required. This is coming from different types, whether it be a health system, a hospital, whether it be a food supply company, it could be a general office staff, lots of different pieces happening here in the standards there. And then finally, just an employer is looking at their overall safety of employees. Can they come back? We don't want them obviously to get sick and then obviously get their family sick and then continue to spread. So certainly a lot of different challenges now for employers, and they're starting to look at this from a a range of opportunity and kind of what they could potentially do with Quest and also other labs as well. So I would tell you that what they're really looking for is a variation of things from a testing perspective. Let's call these programs, for lack of a better word. And these programs range from very intensive programs with lots of interaction, lots of resources, down to using public resources like pop-ups and those type of testing facilities. So I'm just going to walk you through that quickly, and then we'll kind of wrap up on a few items in general. So when we talk about this range of opportunities for employers, some can be a large-scale program. This could be on-site resources that include temperature check, on-site staff, employee questionnaires, a aggregation of results back to the employer. So basically taking the entire group, looking at both serology testing as well as PCR testing, and seeing how that fits into their overall workforce. The middle ground has been very interesting. We've got lots of employers coming to us, just some wanting to do PCR testing, some wanting to do serology, either based off of guidelines they're getting from their different committees, or it's just they're trying to understand more about these two tests and what's best for them in their workforce. So that is actually a very kind of fluid area right now. We're getting lots of requests, but also lots of requests for information to do testing. And I think this will continue as employers start to think about how can I get my employees back to work, but also do it in the best and most economical, but also the safest fashion as well. And then obviously there's been a lot of work right now done with these pop-up locations. This is great for the public. This is also great for, I would say, for small employers. This is an ability for them to use these pop-up locations that are happening at the Walmarts, that are happening at CVS's, that are happening at local and state government type of pop-ups that are happening, mostly for PCR nasal swab testing, but also for serology as well. So these will continue to pop up. I do see this being a kind of a greater good kind of a conversation, and certainly will help employers and employees get better access to this testing, which is critical right now. I think another portion of this will become the healthcare provider. We're seeing lots of information now happening with healthcare providers providing this information. They're using this as a way to bring their patients back, but also give them the right information and the right resources to give to their employer. So just some other quick slides that we have is we just wanted to show you, this is just an example, by the way. This is some of the information we're providing to employers. This just goes through a step process of what it could look like for a certain specific employer. This example has a mix of both PCR and serology, and it gives you a step-by-step view of what this would look like, and then potentially the outcome for the employer, whether that employee can go back to work or maybe should be done in a different way. And then finally, just to give you some ideas, there's always been a lot of questions out there about, do we have enough testing? Is there enough information, enough capacity? The answer is yes. I would tell you from a Quest perspective, and I would tell you from all the other national labs as well, there is lots of capacity out there, as you can see from this chart. Let alone on PCR testing, we're able to do this all across the country at our major laboratories. And certainly we've got enough capacity, and this has been out there in the public for about 55 to 60,000 tests a day. And a very similar story for our serology. Serology we can do obviously at more laboratories because it's done on more common equipment. That capacity is somewhere about 250,000 tests a day. So certainly lots of room to go before we even get close to capacity in both PCR and serology, and certainly an opportunity, we believe, for more testing so people can go back to work, can go back to care, hopefully get back to more of a normal opportunity. So from a Quest perspective, thank you for the time today. We really appreciate this opportunity to have a conversation. And with that, I'll turn it back to Barbara for Q&A.
Great. Thank you, Terry. And if all the speakers can turn their cameras back on, we'll be able to view everybody. There were a lot of questions. I'm going to pose a few of them. And then if there are any questions that you don't get answered, please email me and I'll be happy to direct them because I know we're running a little bit long in this presentation. There were a lot of questions around the testing aspect and whether it's advisable for an employer to mandate that people have to be tested before they come back into the workplace. That was one part of it. Another part was that if people are asymptomatic, that was the concern that you wouldn't even know if somebody had the virus and could be potentially spreading it if they were asymptomatic. So what's the thinking on requiring testing before you come back into the workplace? And this may be more for Terry.
Well, I think I can jump in on that. It looks like, I don't know if Terry's on mute or maybe he had to leave.
Yeah,
but,
he had to leave, yeah.
Okay, so I can handle that. So I think one of the aspects of testing asymptomatic, or what we're really talking about is some type of screening program and the development of screening program. And from an employer standpoint, I think there's a number of aspects to why a screening program is necessary. One is, of course, protecting their employee base, and it's a program that can safeguard and ensure that their employees are working in a safe environment. And the second, depending on what type of a function or what kind of service they provide, if it's a hospital or manufacturing, they may have an obligation to protect their patients and clients as well. And so currently the testing, based on the testing we have, the PCR test is really the mainstay in terms of developing a program to safeguard or to identify individuals who may be able to transmit the disease. Serology can supplement that as a way to identify sort of overall prevalence within an employer group. However, the PCR is really the test that needs to be incorporated in some fashion to screen for potentially infectious individuals, whether symptomatic or asymptomatic. And in the end, it's really based on the risk a group is willing to take versus the resources available to that group to develop this type of screening program.
Barbara, could I just add something to that really quickly, which is I think it's like there's something, and I want to take it away from like the biomedical and make it more about behavioral and public health, which is about, this is about the good of what's good for the public and what's good for the population, right? And it's like at the end of the day, if we want our communities within our workplaces to remain healthy, that we have to, it's almost like we have to give up a little something. And that little something is like you have to test to make sure that everybody else who you're working with remains safe. So it's about creating a common good. And what I come back to all the time as an example is that in the city of Athens, at the height of the epidemic, when people were potentially getting infected, people gave up their rights to just leave their homes. They had to text to leave their homes. And that little bit of giving up an individual right ended up creating an epidemic in the city that was very contained. And so I think it's about the common good. Can we hear Barbara?
Barbara, you're on mute.
Sorry, I was muting while you were all talking. I just said that I'm hearing of other examples around the world too. The other question, and this, I'll make this the last one, and then anybody that didn't get their question answered, please do email me. The concern about the second and third wave, Terry, I think that gets to what you're speaking of, that if we do the right thing this time around and we don't rush back too quickly, that we'll have a better chance of having either no second or third wave, or a lesser one.
Yeah, I mean, it's what are we know what the enemy is now, right? We kind of knew what the enemy was several months ago, but we didn't act quickly enough. Now we know what the enemy is, right? So there are strategies that we can put in place. I mean, we're even thinking about it at our school, and Frank's in conversations too. Are we going to be online in the fall? Are we not going to be online in the fall? And it might seem far-fetched, but I think that these are the little steps we take in what I referred to earlier as the arsenal, right? The toolbox of what keeps us safe. That's going to prevent this huge surge again in the fall. And if we don't do that, we're going to have it.
I think what we're also sensing, and Perry and I have talked about this, and you can see it playing out. There's a tension between how do we keep each other safe, and how do we protect people from what may be years of financial distress.
Mm-hmm.
And people are balancing between keeping my family healthy and feeding my family, and that's a really tough place to be psychologically.
Yeah.
I wish I had an easy answer for that. And I read an article just a couple days ago that said that epidemics end one of two ways: through a medical solution or through a social decision. And I think we're seeing this play out.
Mm-hmm.
Okay. All right. Well, there's clearly much, much more we could talk about. And I just want to, for the sake of everyone, that we said we'd conclude within an hour, we want to come as close as we can to doing so. And I want to give our president, Chip Halleck, a few minutes to comment at the end. Thank you from me for your participation, and look forward to seeing you again. And as I said, we'll be happy to answer questions if you field them to me.
Barbara, thank you for doing such a great job of putting this panel together and moderating the questions as well. I think this morning's session was just incredible in the amount of information that was given to us, and the way it was done about contact tracing and the testing and the behavioral and mental health aspects of this, all things that we as employers and people concerned about our fellow men and women need to be aware of. And I just thought it was an incredibly powerful hour, and really I don't think I've ever been more proud of an organization like ours and our members that have the degree of talent, the degree of commitment to keeping people healthy and making a safe workplace. I'm just incredibly thankful for what we heard this morning and the entire series that we've had here. And again, thanks to Quest for their sponsorship of this outreach. As Barbara said at the beginning, and I won't take long, just to remind you of some of the other webinars that we have coming up, and as well as our networking opportunities with our happy hour tomorrow night, and then next week with our small group networking. Once again, thank you all. Best wishes to you all as we wrestle with the return to work and making our employees feel comfortable and making them safe as they come back to the workplace. So with that, thanks again to our presenters, again, who just, I think, did an incredible job of making the information digestible and understandable for those of us who may not have all the scientific background that they did today. So take care, be healthy. Thanks for joining us. We look forward to seeing you again very soon. Take care.